Hello, my name is Michelle Madden. I am a trainee in nephrology, currently working in my fourth year, my second last year of training, and working at St Vincent's University Hospital in Dublin, in Ireland. And I'm very grateful for the opportunity to speak today, and I hope you get the most out of the conference today. What I thought we'd cover is some topics in nephrology in 2024. First of all, I'd like to present some cases that are presented to our department, how they were managed and how you would work up these patients. And then following on from this, I'd like to cover some of what we consider the future of nephrology to look like, advances in management of high blood pressure, hypertension, as well as transplantation. So we'll start off with a case. So I'd like to present the case of a 41-year-old male gentleman. He had a past medical history of Crohn's disease that was initially diagnosed back in 2006, and he previously had a thyroid cancer that was treated with a thyroidectomy. He had been commenced on infliximab, the TNF-alpha inhibitor, in 2019, and he had been in remission on this treatment. And in 2023, he was changed to a subcutaneous formulation of the same medication due to the ease of its administration rather than intravenous infusions. He was also taking a proton pump inhibitor for acid reflux. In terms of his social history, he was a non-smoker and had rare alcohol use. He presented to the hospital last October, at which stage he had a 5-day history of quite profuse vomiting as well as poor oral intake, feeling nauseated and off his food, and he had a significant acute kidney injury, and I'll go through his bloods in a minute. At this point in time, he did not present with any diarrhea or rectal bleeding or any abdominal pain. On examination, he was normotensive with a blood pressure of 127/85, and his heart rate was 91, and he was afebrile. On exam, he was mildly hypovolemic, but not significantly, and his abdomen was soft and non-tender. He had some blood tests done on admission, which showed a pretty significant elevation in his serum creatinine. So we had a previous reading from approximately 6 weeks before, and he had a normal serum creatinine of 81, that's micromoles per litre. And his creatinine had essentially gone up more than 5 or 6 times in a period of 6 weeks. Of interest, his urea was not particularly elevated. It was within the normal range. His potassium was normal, his bicarbonate was low, suggesting a metabolic acidosis. Albumin was very slightly low, where the lower limit of normal was 35 and his was 31. And C-reactive protein, a marker of acute inflammation or infection, was within our normal range at 4.8. Unfortunately, he did not have a urinalysis done on his admission to the hospital, and you may see this throughout your training, that it is quite tricky to get a urinalysis when patients present to the emergency department. He did have some other laboratory tests done. So he had a negative screen for multiple myeloma, and he had some autoantibodies checked. And the anti-nuclear antibody was weakly positive, which is quite a non-specific finding. And on immunofluorescence, p-ANCA was positive, but we checked antibody titers for MPO and PUR3, which are the ANCA antigens that are associated with vasculitis, and both of these were negative. The impression from the admitting team when he presented to the hospital was that he had pre-renal acute kidney injury. This was due to volume depletion due to a flare of his Crohn's disease. He did have some imaging studies at that time. He had an abdominal ultrasound. He had normal-sized kidneys, no evidence of any hydronephrosis or obstruction, and a simple left-sided renal cyst. He also had a CT abdomen and an MRI small bowel at this point, and this showed that he had a slightly fatty liver. The spleen was mildly enlarged, and some lymph nodes were also mildly enlarged, but there was no evidence of any active inflammatory bowel disease on those scans. So what kind of management did he have? So the suspicion was that he had a pre-renal acute kidney injury due to volume depletion, and this was due to a flare of his Crohn's disease. So he was started on intravenous fluids as well as intravenous steroids as a treatment of choice for a Crohn's flare, and just general supportive care, optimizing nutrition, hydration, monitoring of his urine output, his weights and his bloods on a daily basis. And what we saw during that inpatient stay was actually that his creatinine fell quite dramatically over the course of only 5 days, from 602 to 90. And so this was essentially normalization of his creatinine simply with fluids and IV steroids, and he was discharged home at that point in time. Unfortunately, about 3 months later, which was in January of this year, he re-presented with very similar symptoms, except on this occasion he did have some what was described as right iliac fossa pain. At his second presentation in January, we had a recent serum creatinine only 11 days prior, and this was 99 micromoles per litre, so within the normal range. And this time on presentation, his creatinine was 561, so not quite as dramatic as the first presentation, but very similar levels. And his urea was quite elevated at 21. And on this occasion, his C-reactive protein, suggesting an inflammatory response, was quite elevated at 354. If you can recall, at the first presentation, it was 4.8. So he had an acute inflammatory process going on in this admission. And when we looked back following nephrology consults, he'd actually been admitted to hospital from sigmoidoscopy in April of 2023, so 6 months prior to the admission, October. And at that stage, he had nausea and vomiting, but again, no diarrhea or altered bowel habit. And at that stage, his creatinine was mildly elevated, 167. And he had a CT at that stage, which showed prominent mesenteric lymph nodes, but no evidence of active inflammatory bowel disease. So on this presentation in January, when we were called to see him in the hospital, he had a CT due to the right iliac fossa pain. So this was his kind of third CT in 11 months. And this CT showed that there was no abscess in the right iliac fossa, which was the concern from the gastroenterology team. But what it did say was that both kidneys appeared abnormally enlarged and edematous, or swollen, with inflammatory change around the right kidney in the perirenal fat. So this was likely the cause of the right-sided pain. And the CT, the radiologist who reported it, very kindly suggested that a nephrology opinion would be advised. So at this point, we were consulted, and the question that was posed to us is the cause of recurrent acute kidney injury in this gentleman volume depletion? And some concerning features that didn't quite fit with volume depletion or volume depletion due to his Crohn's disease is that the Crohn's disease seemed to be under fairly good control. All of the CT imaging he had did not show any evidence of active inflammatory bowel disease, and he never had any bowel symptoms, as I mentioned, in terms of diarrhea or abdominal pain. His symptoms on every presentation were with nausea, vomiting, and poor appetite, which could be due to inflammatory bowel disease, but also could be symptoms of uremia due to the acute kidney injury. So at this point in time, it's worthwhile thinking about what causes there are of acute kidney injury. And I do think the best way to divide them is the traditional way of pre-renal, intrinsic renal, and post-renal. And I like to go through pre-renal and post-renal first, as I think it's easiest to assess these and rule them in or out. And then we can move on to the intrinsic renal causes afterwards. So in terms of pre-renal causes of acute kidney injury, what we're concerned about is either just essentially lack of perfusion to the kidneys, or lack of volume being delivered to the kidneys that causes an acute decline in the glomerular filtration rate. Common causes would be hypovolemia, so in terms of fluid losses such as severe vomiting or diarrhea, or hemorrhagic shock. When we think about hypoperfusion, we're thinking about states where there may be sufficient circulating volume, but it's just not reaching where it needs to go. So states of poor cardiac output, or in the case of sepsis, where you have vasodilation and low systemic vascular resistance. And this leads to hypoperfusion and a pre-renal injury. Any pre-renal injury that goes on for a long enough period of time can progress to cause an ischemic form of acute tubular injury. So an intrinsic form of acute kidney injury, which we'll go through in a minute. So assessing for pre-renal causes of AKI involve a thorough volume assessment, checking blood pressure, which can be helpful doing it both lying and standing to see if there's a postural drop, assessing the heart rate as well as general fluid status, and giving a fluid challenge if it's suspected to be the cause of acute kidney injury. In terms of post-renal acute kidney injury, we're talking about obstruction somewhere along the pathway of the drainage system from the kidneys down to the bladder. This is commonly a bladder outlet obstruction caused by prostate enlargement in older men, but we can also see it quite commonly with different types of malignancy. So malignancy within the bladder, malignancy of the ureters, and in females, we often see it with gynecological malignancies such as ovarian or cervical cancer. And the easiest way to rule out post-renal causes of acute kidney injury, first of all, is placing a catheter in the emergency department, and secondly is to organise an ultrasound scan. This will show us any sign of hydronephrosis or hydroureter. So in this case, there was an element of volume depletion clinically on exam, but not perhaps to the degree that would be expected to explain his serum creatinine rise. Also on his first presentation, we go back to the lab testing. We can see here that on his first presentation back in October 2023, while his creatinine was severely elevated, his urea remained in the normal range. And often with pre-renal causes, we would see that the urea would be elevated as well. So that was a clue to suggest that there was something else going on in this patient. So once we've excluded pre-renal and post-renal causes of acute kidney injury, we are left with intrinsic renal disorders. And these can be divided into the different areas, the different sections within the kidney. And although they're all closely interlinked and communicate with each other, it can be easier to think about intrinsic acute kidney injury by dividing it into these compartments. So we have glomerular disorders, such as different forms of glomerulonephritis and direct damage to the podocytes. So we can call that podocytopathies that cause nephrotic syndrome, such as minimal change disease, membranous nephropathy. We've got tubular disorders, such as ischemic and toxic acute tubular injury. So in relation to, say, chemotherapeutic agents, they can cause toxic damage to the tubules. Gentamicin, a common antibiotic that's prescribed. And then ischemic injury. So as I mentioned, any prolonged pre-renal insult can lead to ischemia within the kidney and damage to the tubules. Then we have the interstitial compartment that holds all of the tubules together. And this compartment can be affected by inflammation, and this is termed an interstitial nephritis when it's a drug-related allergic reaction, and pyelonephritis when it's inflammation caused by infection with neutrophils. And then there can be vascular disorders that affect the kidney tissue directly. How do we work these up? So we can do urinalysis, very helpful. As I mentioned, it's worthwhile doing this before a urinary catheter is placed. And in glomerulonephritis, what we see is hematuria and proteinuria. This is an example down at the bottom of a red cell cast. So you can see that this cast, hard to project, but it's made up of lots and lots of small red cells with no nuclei, all kind of stuck together in a tubular shape. And that's a sign that many red cells are getting through the glomerular basement membrane into the urinary space. Tubular disorders often cause a bland urinalysis, or what we may see is these granular casts, which are essentially the tubular epithelial cells dying and going into the tubular space and forming a granular cast. That's associated with acute tubular necrosis. Interstitial disorders, we may see white blood cells in the urine due to the inflammatory infiltration, white blood cell casts. And then again, with vascular disorders, we do not see much within the urine sample. So when this gentleman represented in January of this year, he did have urinalysis done. And on this occasion, he had a trace of blood and 1+ protein. So a fairly unremarkable urinalysis. And a urine protein to creatinine ratio of 15 milligrams per millimole, where 14 is the upper limit of normal. So very marginally elevated. At this point, as I mentioned, there were a few things that were pointing away from a pre-renal acute kidney injury. One was that the CT scan had suggested that his kidneys appeared edematous and swollen, which suggests that there may be something going on within the tissue itself. And the other was that the urea was not particularly elevated and he didn't appear very volume deplete on exam. We know that he wasn't obstructed because he had multiple rounds of CT and ultrasound imaging. So we were concerned about an intrinsic acute kidney injury. And I think given the edema appearance of the kidneys, And the timing that he's had recurrent acute kidney injury since changing his medications for inflammatory bowel disease, our concern was that he could have an allergic interstitial nephritis. Patients with inflammatory bowel disease are also at increased risk for glomerulonephritis, such as IgA nephropathy, which doesn't tend to present with recurrent episodes of acute kidney injury, but it was something that we thought might be an underlying pathology that we would see in the kidney tissue. So the only way to find out what exactly is going on in an intrinsic acute kidney injury when it's not clear from the history is to do a kidney biopsy. So that's exactly what happened as the next step. This here is a picture of the light microscopy from the kidney biopsy. Apologies, I got cut off there briefly. So this is this gentleman's kidney biopsy. So this is kind of a higher power field looking at a larger section, a medium section of the kidney. I'm not sure how much training you've had in looking at pathology to date, but this is a light microscopy image with a H&E stain, and you can see a glomerulus in the middle of the screen. But the main finding in this kidney biopsy is that there is a diffuse infiltrate around the tubules. So you can see several kidney tubules here. And amongst the tubules, there's a lot of lymphocytes, but there's also kind of darker, pinker colored inflammatory cells as well, which are eosinophils, and that would be confirmed in a higher power view by the pathologist. So the kidney biopsy here was consistent with an inflammatory process in acute eosinophilic interstitial nephritis, which would be in keeping with a drug-induced reaction. So what happened at this point? The concern was that the change from IV infliximab to the subcutaneous version had predisposed this gentleman to developing acute interstitial nephritis. His first acute kidney injury occurred only 2 months after starting the medication, and he'd had worsening severity of acute kidney injury with re-challenging of the medication. And he'd been partially treated by receiving steroids on every occasion during his admissions, as there was concern about an inflammatory bowel disease flare. So he was being effectively treated for a period of time, but then being re-challenged with the same drug, and that was resulting in recurrent acute kidney injury. So due to the long-acting nature of infliximab, he was started on steroids again with a much slower taper, and infliximab was discontinued altogether, and he was changed to a new treatment, a JAK inhibitor for inflammatory bowel disease. He was seen back in clinic in April of this year, and at this stage, urinalysis was negative for blood, no proteinuria, and his creatinine was 108 micromoles per litre, and the previous baseline was 80, so not quite back at his previous baseline, but significantly improved from its peak with normal inflammatory markers. So I think the take-home points from this case: it is true that the commonest causes of acute kidney injury are acute tubular necrosis, usually driven by sepsis, and then also pre-renal disease. It's important to consider post-renal causes of acute kidney injury, as they're easily assessed with imaging. A simple ultrasound will rule in or out the presence of obstruction. And any patients that have a history of intra-abdominal malignancy, such as both gynecological malignancy and urothelial malignancies, you should always have a high degree of suspicion in these patients that obstruction may be the cause of their acute kidney injury. Number 3, if the cause is suspected to be an intrinsic acute kidney injury and there's not a clear cause, for example, sepsis causing hypotension and hypoperfusion, then if we're considering other causes such as a glomerulonephritis or interstitial nephritis, a kidney biopsy can be very helpful to determine the diagnosis and guide treatment. And it's always worthwhile checking a urinalysis for these conditions. And ideally, this should be done before placing a urinary catheter in the emergency department, as often we do see blood and protein on catheterized samples. Moving on to case 2. So this is a case from the outpatient department. So we have a 72-year-old gentleman who's been referred in by his general practitioner from the community, and he has a past medical history of type 2 diabetes, high blood pressure, and elevated cholesterol. He's on insulin, metformin, ramipril, and atorvastatin. and he's an ex-smoker with a 20-pack-year history with rare alcohol use. On examination, he is hypertensive, and his urinalysis has 3+ protein and is negative for blood. This patient has been referred to us by his GP, who says this gentleman has a creatinine of 200 micromoles per litre. He's got albuminuria, so protein in his urine, an eGFR, an estimated glomerular filtration rate of 28 mils per minute, which is declining every year. And the patient, when he comes to clinic, he said, "My doctor says I might need dialysis. And do you think this is true? And how soon am I going to need it?" So he's quite worried turning up in the department, and we want to be able to give him some answers to these questions. So we need to dig a little deeper. We know he has diabetes and hypertension, but is this the cause of his kidney disease? So when you ask him a bit more about his diabetes, he's had it for 20 years at this point in time, so since his early 50s, and he's been on insulin for 15 years at this time. So he was started on insulin relatively early on the course of his treatment pathway. He also has diabetic retinopathy, which requires laser treatment. And often we do see that retinopathy and nephropathy go hand in hand. He has had no history of peripheral vascular disease, but you can see that he is an ex-smoker with a significant pack-year history, and that can cause accelerated progression of chronic kidney disease. He also is hypertensive on exam, so he has several risk factors for kidney disease. The Kidney Disease Improving Global Outcomes Group, KDIGO, have staged chronic kidney disease based on both GFR, so your glomerular filtration rate, as well as the amount of albuminuria. And this provides what's called a heat map and tells us and doctors in primary care what this patient's risk of having progressive kidney disease is. But it doesn't give us any numbers, it just kind of gives us an overall picture. And anyone, as you can see, with stage 3A onwards chronic kidney disease has quite an increased risk of progressive kidney disease. So it's hard to reassure patients in clinic when this is all the information that you can give them, and is often all they know in advance of coming to nephrology outpatients. A very useful tool that we use in the kidney clinic, and that I think will be useful for you to know as well, is the kidney failure risk equation, or the KFRE. This uses 4 variables to estimate a patient's risk of requiring dialysis or renal replacement therapy at both 2 and 5 years. And it only requires a few simple baseline readings. So you need to know the estimation of albuminuria, the sex of the patient, the age of the patient, and their current glomerular filtration rate. This equation was initially developed in 2011 using data from 2 independent Canadian cohorts of patients with CKD, and then it was subsequently validated in 2016 using data from more than 30 countries spanning 4 continents. So it's a very well validated equation to use. Also very straightforward to use. So if you type in kidney failure risk equation into Google or any search engine, you'll get the screen up straight away. So plugging in the parameters for our patient here, he's age 70, a male patient. He's not from North America, but I ticked the wrong box there. And his current GFR is 28 mils per minute. And based on his last urine sample, his albumin to creatinine ratio is elevated at 150 milligrams per millimole, which is somewhere between 1 and 2 grams of protein per day. When you plug those numbers in, you receive feedback that tells us he has stage 4 chronic kidney disease that you would know based on his GFR. And it tells you that what his risk is at 2 and 5 years of needing dialysis or transplant. And then it gives some thresholds at which point patients should be referred to a nephrologist, and when they should start having planning for transplant or fistula. So you can see in this gentleman's case, he has a risk of needing dialysis of about 15% at 2 years, and that those with a risk of greater than 20 to 40% should be planned for dialysis. So we have a bit of time. We can reassure him in the clinic that while he is at risk, we're hopeful that we would be able to monitor him and follow him over the time, and we're not going to be jumping into dialysis straight away. This kidney failure risk equation was looked at in this prospective study in San Diego of 250 patients. These patients all had stage 3 to 5 chronic kidney disease, and it was prospective. So at the outset, patients, doctors, and the equation estimated whether the patient, what the likelihood was that the patient would be on dialysis at 2 years. So patients and physicians were asked on a scale of 0 to 100, please give your best likelihood of this patient being on dialysis or needing a kidney transplant in 2 years. Patients were then followed up for that 2-year period, and it was found that over 2 years, 13% of them had reached end-stage kidney disease. In terms of the patient-reported outcomes, about 1/4 of them gave estimates that were more optimistic than physicians, so they weren't really aware of the severity of their kidney disease, and about 1 in 10, so 10% of them were more pessimistic. The physicians, so the doctors, and the kidney failure risk equation had the strongest correlation. So physicians and the equation did pretty well in comparison to each other, but the equation itself had the best accuracy in assessing the risk of chronic kidney disease. So no patient that the kidney failure risk equation estimated had a risk of less than 15% reached end-stage kidney disease at 2 years. So essentially the outcome of the study was that we should use the equation. It works better than both physicians and patients' estimation of needing dialysis at 2 years, and that physicians tend to overestimate the risk in general. What's also very useful about the risk calculator is that they give you some guidelines on how we can reduce this risk and what medications you might consider introducing in these patients. And so this can be used in primary care, it can be used by internal medicine doctors and nephrologists as well. And so it tells you a blood pressure target, which I omitted here, which will be 130/80. And so a good blood pressure target will reduce the risk from 41 to 32%. Introducing an ACE inhibitor, an A or B, will reduce the risk almost by a third, from 41 to 28%, and adding an SGLT2 inhibitor reduces it to 22.58%. So overall, the patient's risk by being on optimal medical therapy can be halved. And if you recall, this gentleman, he was on metformin, he was on insulin, but he was not on an SGLT2 inhibitor, and he was only on 2.5 milligrams of ramipril, where the maximum dose is 10 milligrams with an elevated blood pressure. So there's some work that we could do. We can add the SGLT2 inhibitor in, and we can increase the ramipril dose, and hopefully over time we will see that his risk of progressive kidney disease is less. So the main learning point from this is the importance of using the kidney failure risk equation, and that it can guide you in terms of treatment decisions and give you facts and figures to present to the patients that can often be quite reassuring. Okay, moving on from some current cases, I just want to talk briefly really about 2 promising treatment options that we have coming forward in the future. The first relates to treatment for high blood pressure. So this medication, this paper was published in the New England Journal last July, and looks at a medication that was difficult to pronounce, zilebesiran. And this is essentially a long-acting injection that can be given for high blood pressure. So as I'm sure you're aware, hypertension is a major risk factor for ischemic heart disease, stroke, and chronic kidney disease, and it is actually the leading preventable risk factor, in a modifiable risk factor in terms of death from cardiovascular causes worldwide. But we're not very good at treating high blood pressure despite our best efforts. Nearly half of the patients do not reach the guideline recommended blood pressure targets, and that's due both to physician inertia and not titrating up the medications, but also compliance is a huge factor, and many patients don't enjoy taking daily blood pressure tablets and aren't aware of the need to be on tablets on a daily basis. This medication acts on the renin-angiotensin system, which plays a major role in the development of hypertension, and it's an investigational product. So this study was a phase 1 trial, and it inhibits the production of angiotensinogen in the liver, which is the precursor to angiotensin 2 and aldosterone production, and plays a key role in the pathogenesis of hypertension. So this drug was given to 100 patients, as I mentioned, in a phase 1 trial, and it was given as a single dose subcutaneously. And they looked at blood pressure control. They had several different doses, 200, 400, and 800 milligrams. And what we see is that at 8 weeks, blood pressure had dropped by 16.8 points in the zilebesiran group compared to placebo. And at week 24, that was a sustained blood pressure effect. So that's almost 6 months after the injection, the infusion was given. There were no deaths, no unplanned hospitalizations, and no patients need to be treated for low blood pressure or high potassium levels, no worsening of kidney function. And so this was a consistent and sustained effect. And this would offer the potential for twice yearly or maybe 4 times a year subcutaneous administration rather than taking a daily tablet. So this is a very promising treatment that would lead to happy physicians and happy patients. It needs to be studied some more, but I think we're going to see it coming down the line. The final topic I want to talk about is xenotransplantation. And so this is essentially transplanting an organ from one species into another species. And this is very topical in nephrology at the moment, as in March of this year, the first pig kidney was transplanted into a living human. And I'll go through a little bit of the previous research that was done in this area. So in Ireland, we have approximately 150 to 200 kidney transplants performed per year, which you can see in the red bar down here. However, the number of patients that are on our kidney transplant list is at least a consistent level, with periods of time where it's rising even higher. So there are many patients waiting for a kidney transplant. The average wait time in Ireland is between 2 and 3 years. A kidney transplant really is the therapy of choice for end-stage kidney disease. So anyone who's eligible, we do try and get them transplanted. Transplantation of kidneys depends on both living donors and deceased donors. And as I said, the numbers on the waiting list exceed the numbers transplanted every year. The median time on dialysis prior to the first transplant, it depends on whether you have a living donor or deceased donors. If a living donor gets worked up quickly enough, you will not have to spend too much time on dialysis. But you can see that the overall time spent on dialysis is about 30 months, and we haven't really been able to get that down over time. So xenotransplantation is the process of grafting or transplanting organs or tissues between members of different species. And this was first done back in 2022, and it was presented at the nephrology conferences at the time. And it was done again in the United States in 2 different centres. And you might wonder why we choose pigs rather than other animals such as monkeys or primates that are considered quite similar to humans. Pigs have a similar blood flow blood flow compared to humans. We eat very similar foods and we balance fluids and electrolytes in a very similar way. And we actually have EGFRs that are quite similar, and their kidneys are a better size match than primates. So they're actually a better fit to humans rather than the primates that we would think of as our most close relatives. There are some issues with pigs. So there are some genetic differences. The pigs have these carbohydrate antigens that we actually have preformed antibodies against. And so if the pig kidney is transplanted genetically unmodified, what we see is very severe hyperacute rejection of the kidney because we have preformed antibodies against these antigens, and the graft will be destroyed within 24 hours. Pigs also have issues with latent viral infections, CMV and retrovirus, and the pig blood pressure is less than the human blood pressure. So over time, there's a concern that the pig kidney might wear out quicker than a human kidney. There are some ways to overcome these issues. So for the immunological risk, the pig kidney is genetically modified by deleting genes by CRISPR technology, which remove the carbohydrate antigens, so they're no longer present in the pig tissue. There's also deletion of some growth hormone genes and insertion of 6 human genes that make it a bit more similar to our immune system. The pigs must be reared in a pathogen-free facility. They're reared specifically for transplantation to keep them free of any viruses. The first pig to human kidney transplant was in a deceased person back in 2021. His name was Jim Parsons. He died in a motor vehicle accident, and he always wanted to donate his kidneys as an organ donor. However, he was found to have some reasons that he could not donate his kidneys. So his family were approached and asked would they agree to be part of this research study where a pig kidney would be implanted into his body and he would be kept alive for several days to study the effects. And his family very kindly agreed. So they removed both his native kidneys and then genetically modified 2 pig kidneys, which were implanted into the gentleman. And what we saw was that he had good urine output after the kidney transplant, but the creatinine did rise. Now that may be related to kind of changes of being on a ventilator and being in an intensive care unit. So it was a successful study. So this has progressed, and as I mentioned, in March of this year, this was the first gentleman to receive, as a living patient, to receive a genetically modified pig kidney. He was 62, it was done in Boston. He had type 2 diabetes and high blood pressure and had been on dialysis for a long time. He'd had a previous kidney transplant that had failed about a year ago, and he was having a lot of issues on dialysis from the reports. He was in and out of hospital every week, and he was having issues with access for dialysis. And so he agreed to be part of the study, and he underwent a xenotransplant in Massachusetts General Hospital in March of this year. Unfortunately, he did pass away only about a week ago, and it's reported that it was not related to complications from the transplant, but very sad that he's passed away. But he has really paved the way for this area that is going to be studied further in the future, and there will be more trials done. And his family did release a statement that said, after his transplant, Rick said that one of the reasons he underwent the procedure was to provide hope for the thousands of people who need a transplant to survive. Rick accomplished that goal, and his hope and optimism will endure forever. So on that note, I hope I've given you some optimism for the future of nephrology: less medications, more transplantation. We brought you through some cases that we had in our department, both acute kidney injury and chronic kidney disease, and giving you some tips on how to manage it. And nephrology is a very rewarding career, and I wish you all the best of luck in your training. And thank you very much for allowing me to speak today.